Good evening. For those of you I haven't met before, my name is Shanthini Naidu and I'm the CEO of the St Vincent's Curran Foundation. I'd like to welcome all of you to tonight's Inside St Vincent's seminar on Can Dementia Be Prevented? The latest on dementia and Alzheimer's research. I'd particularly like to welcome everyone here at the Garvan, but also everyone online, wherever you are. Thank you for joining us. Before we begin, I would like to acknowledge the Gadigal people of the Eora Nation, the traditional owners and custodians of the land on which we gather here tonight at the Garvan Institute of Medical Research, and pay my respects to elders past and present. I would also like to acknowledge Charles Curran, AC, Chairman of Trustees of the St Vincent's Curran Foundation, joining us online tonight, Louise Walsh, Director of the St Vincent's Curran Foundation Board, who is here with us tonight, and also Dr. Peter Bentivoglio, Emeritus Chair of Neurosurgery, St Vincent's Clinic, who has been a driving force for the development of neurosciences research programs across the St Vincent's Healthcare Precinct. Thank you for being here tonight, Peter. I wish to pass on apologies from our Foundation Chairman, Richard Haddock, and also apologies from our long-term donors, Peter Duncan AM and Stephen Dutton from Pertec, who really can be considered the founding donors of our neurosciences research programs and our Brains Trust, as we call it. It really is wonderful to see so many of you here tonight in person after a very long time. And as I was saying to some of the new people who've joined us tonight, it's a bit like a family reunion after so many years of being apart. I'd like to thank our panel of expert clinicians, Professor Bruce Brew, AM, Dr. Elisheva Vissel, and Dr. Nicholas Ingham, who have made themselves available on this important day. Today is World Alzheimer's Day, and it's also Dementia Action Week. And at St Vincent's campus, it's Research Week. So we thought it was very appropriate to highlight the extraordinary work that is being done in this area here at St Vincent's. As we grow our Brains Trust at St Vincent's, we have a long-term goal of raising the status and profile of our neurosciences research initiatives and the incredible clinical trials and the multidisciplinary collaboration that is underway across our campus. In doing so, we are delighted to be able to welcome Professor Bryce Vissel and his team to the precinct, coming from UTS, to join our Centre for Applied Medical Research. And Bryce and his scientific team will work really closely with all our leading clinician researchers to drive our ambition to establish a Centre of Excellence in Brain Health. So tonight we'll be starting off with talking about a model for dementia prevention and also, can it be prevented? Of course, there's so much work being done around the world on cures and treatments, but in the first place, is it possible to actually prevent it? So I will now hand over to our wonderful supporter, Sophie Scott, the ABC's national medical reporter, to lead our panel and hopefully give us lots of insights into how we could prevent dementia. Thank you.
Thank you. Thanks, Shanthini. Thank you. I might just get everyone to check that their phones are on silent, just a little bit of housekeeping before we get underway. Just pop your phone on silent. I'm also delighted to be back here on World Alzheimer's Day. And as many of you know, St Vincent's is really at the forefront of so many different parts of research and neurology and neuroscience is a huge focus of St Vincent, so this is a great topic for us to be talking about this evening. And St Vincent's has really grand plans for this multidisciplinary, fully integrated dementia prevention clinic that we're going to talk about tonight, which will be really so important in the future and hopefully not too far down in the future. And that's going to be headed by both Professor Brew and Dr. Elisheva Vissel, and I'll introduce them properly in a minute. And the goal, though, is to have that centre of excellence for dementia and for brain health. And it's not going to be just about dementia, it'll be Alzheimer's, things like using stem cell repair, brain connectivity, and we'll talk about geriatric medicine as well and what exactly that is, and the increased sort of challenges of the fact that we're all living longer, which is great, but that does bring with it some challenges as well. So we'll talk about that. But first of all, I'll just introduce our panel. So we have here Professor Bruce Brew, AM, and he's a senior consultant neurologist here at St Vincent's and a conjoint professor of neurology at UNSW and the University of Notre Dame as well. He's head of Neurosciences Research at St Vincent's and director of the Peter Duncan Neurosciences Research Institute. And his work covers dementia, Alzheimer's, autoimmune-related diseases, and viral brain infections. And he's also doing some really interesting work and involved with the work that's being done at St Vincent's for long COVID, in the long COVID clinic here at St Vincent's as well. And so we're very honoured to have him with us this evening. Give him a big round of applause. Thanks, Bruce. And now I'd like to introduce Dr. Elisheva Vissel. She's a clinical neurologist and neurophysiologist here at St Vincent's. And she's also a conjoint lecturer at UNSW and the University of Notre Dame with experience in clinical neurophysiology, which are things like nerve studies. And she's got a particular interest in cognitive disorders like Alzheimer's and dementia. And her PhD that she's undertaking will develop a personalised protocol for preventing the progression of dementia. And that's what the future of medicine is all about, the personalised approach as well, which is fantastic. So we can talk about that and what that could potentially do to help someone who might be at the early stages of memory impairment to stop them getting into full-blown dementia. And be using things like imaging and biomarkers and things like that. And this work is going to be undertaken not only with the great researchers here, but also with amazing collaborators overseas, which is really exciting. Particularly there's a Professor Richard Isaacson, who is in the US, and he's been really a world leader in dementia prevention. So thank you, Elisheva. Thank you for being here. Give her a round of applause. Thank you. And last but not least, Dr. Nicholas Ingham is a senior geriatrician here at St Vincent's, and he evaluates and manages the care of older people, and that's the physical, cognitive and functional and social issues of older adults, and that's everything from dementia, delirium, polypharmacy and other medical problems. And he also participates in research and clinical trials, so give him a round of applause and welcome Nick. And there will be an opportunity for you to ask questions here in the audience and also online as well. So there'll be, while we're listening to our speakers, make sure to think if you've got any questions at the end, we'll definitely make sure there's time for questions because we do want to hear from you. This is your event, and if you're at home watching as well, the same goes for you. If you've got any questions, we'll have plenty of time at the end. Okay, let's start with you though, Professor Brew. And this is probably the question on a lot of people's minds. You know, we hear a lot about the rates of Alzheimer's and the rates of dementia. What can we do, and what can we do as individuals to prevent getting conditions like that?
So the answer is complex, but I think the first step is awareness, and the second step is to believe that you can make a difference, and you can. There's a lot of evidence to say now that somewhere between 30 and 40% of dementia on a worldwide basis, and at a population level, obviously, is preventable. And there are 12 identified risk factors, each with varying levels of evidence, but 10 of which have pretty good evidence. The WHO has got its own document titled Dementia Prevention, and that was back in 2019.
So if you had to pick out for the audience tonight, say, a couple of key things that they should all be thinking about, am I doing this to prevent dementia? What would you say to particularly, well, any audience, but our audience tonight who are obviously really interested and want to do whatever they can to prevent dementia?
So I'll just briefly outline the 12 things because they're easy to remember if you're a fan of The Simpsons. Just remember Homer.
Homer. Okay, we can all remember Homer Simpson, okay? That's what...
So,
remember the whole name, Homer Simpson?
Just the mental image.
Okay.
So he's overweight, which is terrible. He drinks too much, which is not good. He has probably glucose intolerance or possibly diabetes.
Blood sugar problems.
Yeah.
Yep.
Probably blood pressure as well, and probably cholesterol as well. He doesn't exercise, only his right arm. And he doesn't engage in cognitive activities of much description. He has some limited social contact.
Going to Moe's bar, that's about it.
And I think those are all addressable factors at a very practical level. If you watch your diet, physically active, cognitively active, they're the main things. The other things are pretty much standard medical care, blood pressure, cholesterol, glucose control.
And what about, you mentioned social interactions and is that an important part of it as well, keeping socially connected and...
Yes, is the short answer. It's 2 of the 12 that didn't have a sufficient evidence base for WHO to give a formal recommendation. I think that's because it's an entity that's hard to quantify, and it's an entity that has gained traction only in the last few years and therefore hasn't got a solid research base yet. But it's not a tall order. Just be nice to other people and interact with them.
And while we're talking about prevention, Sheva, I might bring you in here. Are there things that you're looking at that you want to develop for your sort of personalised protocol that you're looking at that will help people prevent dementia? What are the sort of things that you're looking at and you're going to be focusing on?
So just listening to Professor Brew, there's lots of different things and lots of different places that any one individual may be able to get benefit because their specific risk factors are unique to them, and a recognition that fundamentally everyone has their own unique set of risk factors. When we think about dementia prevention from that kind of real personal aspect and recognize that at the end of the day, it is true that you can make tremendous change by maybe giving everybody the same thing and affecting 50 people. If you give each person the things that they need, potentially that impact is different, and potentially that impact is better. And when we think about all of those different recommended risk factor changes that any one person can do, we really, it is true that all of you can go home and do them, practice them on your own. You can make yourself more available socially. You can engage cognitively. You can exercise more. Those are real and tangible things that you can do. Often from a medical perspective, what a doctor can do is then look at really the unique risk factors, that specific profile that you or any one individual has, and then try and tailor that approach to that person. So, person A has high blood pressure, has a little bit of diabetes, has, sleep apnea that's really affecting their sleep, has a poor diet. You can then try and tailor something that is unique to them. And that hopefully really changes the way we think about prevention, because it's then a very different, it's not a generalized approach, it's a recognition that really the risk factors that you have or any one person has are hopefully the risk factors that we can address for them, and that therefore the outcomes should be better.
That sounds great.
And I think the other important thing is that I think a lot of people have this idea that what we've said is ho-hum, to be frank.
Yes, yeah.
That it's
just
not enough.
lifestyle.
That it's not enough.
Yeah, so it's not enough detail,
Not
but there is
significant
detail. There is detail in the WHO document, and there are, if you can have a personalised approach, then you can drill down and say, well, what sort of exercise, how much sort of exercise. Blood pressure, obviously it's important, but it needs to be monitored and properly managed.
Yes,
So
good blood pressure control.
That personalised approach then can drill down and help you in more precise terms.
Yes, Shiva?
Oh, just that I think that maybe the way to think about it is a kind of analogy of cardiovascular risk, that one could say to somebody, let's wait, when you have a heart attack, come to me and I'll try and fix your heart. That's
not a good
unacceptable.
approach, let's face it.
We don't do that anymore. We recognize that there's risk factors. The person might feel completely well, but that blood pressure affects their risk, that their cholesterol profile affects their risk, that their diet, and those things are absolutely taken for granted, that if you do those things, that will help your individual cardiac risk, and that in turn, that means better outcomes for the person. It is true that making those changes, it's hard to know they didn't have a heart attack because they never would have had one. They didn't have a heart attack because the changes that they've made. And lots of data and statistical analysis help you do that when it's part of research environments. But that really a recognition that there are changes that we can make, and that those changes, much like we take them for granted with cardiac health and with so many other diseases, absolutely should be part of our cognitive health, and that we can make the same kind of difference for each person by targeting their risk factors and making changes.
And Nick, is that something that you, as a geriatrician, I might
Yeah.
put you in here?
I was just going to make the point, Sophie, too, that probably never too late to adopt this approach in life either. Whilst we sort of tend to think the greatest weight of evidence for interventions for prevention probably around midlife intervention, there's almost certainly good evidence that continuing and adopting this sort of approach, even into later life, and even when maybe some subtle cognitive changes are developing, are probably still beneficial.
So even at that, what they call the mild cognitive impairment?
Yeah, so I see a lot of elderly patients with early dementia syndromes, or even subjective memory complaints, where we spend a lot of time talking about these lifestyle modifications. And patients, I think, are quite keen to, are often very proactive as well, and like this sort of approach, rather than being told that, well, this is just part of an ageing process, it's not surprising, off you go. I think this sort of proactive intervention appeals to lots of people, and is certainly a benefit.
And
So I think it's really important also to emphasise that if you've got a family history,
that's going to be my next question. Yeah, so it's great. Yes. So what
Okay.
about if you have a family history? What does that mean?
so it may mean nothing, but if it truly is a family history with a close relative and they have dementia at a relatively young age, I know there's a mindset, at least in some in the community, that has the approach that, well, I'm on a track towards dementia and I can't do anything about it. That's not true, and there's evidence to support that. The strongest genetic risk factor is ApoE4. It's a sort of it's a fatty protein.
And if you have that gene, that ApoE4 gene, there's one particular gene. That doesn't mean you're going to go on and get dementia, though, does it?
It's not inevitable. It just increases your risk rather significantly. But the really interesting and important factor is that there have been several what are called multi-domain prevention trials, and there's no signal for those in the trial who are ApoE4 positive doing any worse. So they did benefit. So the message is these interventions can be helpful, and just because you've got a risk factor in terms of family history does not mean you're on a course that can't be altered.
And what about if you have either a sibling or a parent with dementia, which some people do have? Is that considered a close family? Or how much does that increase your risk?
Yeah, it depends on the actual genetic risk factor.
So it's not just that clear cut then.
No, but there's no question it increases risk. But if you have if your mother at 90 becomes demented, it's probably not an issue. Yeah.
But if it happens, say, when she was much younger, like say 50
60s,
or 60s.
70s, yes, yep.
Okay, so it's a bit, so the same, that's often the same with cancer risk as well, isn't it? If you have a relative with cancer who gets cancer, say, in their 90s versus someone who gets cancer, say, in their 50s, it really significantly changes your risk.
Yeah, and I think that really speaks back to that same kind of analogy of cardiovascular risk, that if somebody did have a family history of heart disease, by all means, you just start checking early and making those changes early. And really, dementia of old age really, by and large, has much less in terms of a genetic risk profile. And those risks that we have, such as ApoE4, really, hopefully, like these recent studies have suggested, may not make much of a difference in terms of our capacity to make change. ideally also, because we continue to learn about them, we continue to be able to target what particular risk profile that person has, and therefore, as we continue to learn what changes particular genetics might mean for that person, how we might be able to further target it to fit their specific needs.
So Shiva, I might just stick with you. Can you explain to the audience the clinic that you want to set up, or this preventative model? Why would that be, why is it going to be so unique, the model that you want to set up?
So, you know, I think that I guess just to go backwards, there is this sense, I think, in the broader community that dementia prevention is not possible. And that when somebody says that it's possible, that it's said really just because we don't have a treatment. It is true that we don't have treatments, but it is equally true that we do have evidence that prevention can be helpful. And it makes sense that prevention can be helpful because we do increasingly recognize that there is certainly multifactorial pathogenic changes that happen that are reflected in a person's cognitive loss. And so making changes to those risk factors do certainly show that potential for reducing risk for that person. When we think about prevention models, there are lots of models for brain health increasingly, as there's a recognition that it's not just useful, it's important, and that if you have access to something that could affect outcomes for people, by all means those should be, you are obligated. You have to do them. You can't say to somebody, we'll wait until you have a heart attack, or we'll wait until the dementia sets in, and then we'll, I don't know, and then we'll need a lot of care. That's not acceptable. And so recognizing that there are things that we can do, then I guess the question is, how do we set up a model of care that might best take those risk factors and translate them into the best outcomes for the person? And so I guess the aims of the clinic would be threefold. The first aim would probably be to, most importantly, treat the person. So a recognition of the individual person's risk, look at all of the things that affect their lives, look at their networks, look at their vascular risks, look at their metabolic risks, look at the things that we know that impact on their risks of developing dementia and make changes. So ultimately, that's the goal. The second goal, of course, is that you can do lots of things and say, oh, person's doing well, that's great. You don't actually know the person's doing better unless you really look at it and analyze those differences that you're making. And so
tracking how they're traveling in terms of how they, whether they are progressing down further.
Yes,
yep.
And setting it up in a research clinic so that we can look at that, we can analyze the data, we can say, this doesn't seem to be working or this does seem to be working, so that the things that you do are meaningful and that they do make a difference. And then I guess, so analyzing our own work and making sure that those changes and that those things that we do really do have impact. And then thirdly, really to make sure that in order for any kind of clinic to be a clinic of excellence, it has to be linked in with research and with a broader global community of excellence. And so, I think that we're very fortunate here at St Vincent's Hospital. I think, our links with Professor Bryce Vissel, my husband, whose work at the Center of Neuroscience and Regenerative Medicine has been very helpful and influential, certainly in terms of the capacity for change, but linking into the forefront of research and helping that translate back. And so those are our international collaborations as well, and our neuroscience here at the hospital.
And the clinical trials, of course, yeah.
Yeah, and the clinical trials. Is it more difficult to get funding for prevention rather than, say, like funding for a treatment, or because people, I know certainly with when you see research grants and you look at the budget or the health budget, the amount that's put towards prevention is really, really quite small. So how difficult is it to get funding for preventative measures?
Next question.
I think
It's terrible.
That's why we need philanthropy.
No, I mean the interesting thing is that I think this year alone the amount that's been invested in Alzheimer's treatment funding through pharmaceuticals and through investment, global investment, is something like $4 billion. I'm sure that investment in prevention is much, much, much less. And I guess at the same time, if you look at the outcomes from dementia treatment models, the outcomes so far very, very unfortunately have been something close to 0%. And the outcomes with prevention are certainly, probably, something between 30 to 40%.
That's great. I was going to ask you, I mentioned the international collaborators that you're going to be working with, Professor Richard Isaacson. What does his work suggest in terms of the most marked potential to help prevent dementia? What does his work suggest that people should really be focusing on?
So, Dr. Isaacson, who, we've been very lucky to work closely with in the United States, he was really one of the first people in the US to really say that he felt that dementia prevention, that preventative neurology, that you could do something called preventative neurology, and that you could try and make a difference in terms of risk factors for people. And so really, 15 years ago, he wrote a book on dementia prevention.
So it was back in 2013, I think, he set the clinic up, and that was when he was at Cornell in New York.
Yeah. So that would have been a pretty pivotal moment then to sort of really turn the focus onto prevention rather than just the focus on treatments.
Yeah, and I think it was very difficult to, just the language was difficult to accept because, people did not have a sense that you could put those two words together, that you could say
dementia and prevention.
Dementia and prevention. And so he really did pioneer a different way of thinking, and that really has evolved to be much, much more accepted globally as lots of research has really confirmed what he had said and and the things that he had shown, which were the changes that to some extent not unexpectedly are helpful for cognitive health and are helpful in reducing somebody's risk.
And just with those measures that you've both mentioned, how much do people need to change their lifestyle? Is it a matter of just looking at improving, doing a little bit more exercise and, getting your blood pressure under control a little bit more, or are we talking about significant changes too? I mean, I guess it depends what the baseline is. Are we talking Homer Simpson or are we? But I mean, do even small changes make a difference, I guess, in prevention? Or do people need to be really thinking about, putting a bit more effort into?
So I guess the best way to answer that is it's a single domain trials.
Where they look at just one intervention.
One thing like diet or exercise have a very uninspiring benefit.
So
there is a benefit.
So you need to be
very
looking
small. Has to be multi-domain.
Right. So you need to be looking across those 10 to 12 factors that you talked about to see. And I guess that's really where the personalised part comes into it as well, doesn't it? Because you can say, well, what do I really need to address, rather than, might not be 12, it might only be 6 of those 12. You might already have a few of them under control.
Yeah.
And I guess that's the exciting part, isn't it? That you're not. It's not a one size fits all for prevention.
No, exactly. And this is where tech can really help us in terms of smartphones and smartwatches. So a step count, for example.
My watch just told me to stand up, but I just wouldn't.
So if you
shake it away. Yeah.
If you can average 10,000 steps a day, you'll reduce your dementia risk by 50%.
Wow, did you hear that? Did everyone hear that? 10,000 steps a day reduced by 50%.
50%. 3,000 steps reduces it by a third.
That's great. So even 3,000 steps reduces it by a third.
Yeah. So with tech, you can actually have that personalised approach and be quantitative, and you can hound the patient.
And it is really motivating. I've got to say, I resisted getting an Apple Watch for a long time, but it is very motivating when you see that you've how many steps you've done, and you've closed all the rings for the day and things like that. So I find it quite useful.
At some point you become, I feel like I'm disappointing it all the time.
I know, you're like, oh, I'm sorry. I know, you don't want to disappoint it, yes. And you can share data with people. And
Yes, you can still do it.
Another point to make about a lot of these lifestyle modifications we're talking about for cognitive health is they translate as well to many other health benefits in later life, which I see across different organ systems. So, for instance, cardiovascular health, mental health is generally improved with exercise and all those sorts of things. Cardiovascular health, blood pressure control, glycemic control, all of these sort of things respond to various lifestyle medications. So the news is all good for these.
Yeah, so exactly. So it's, if you are able to make these changes, you're going to get the benefits not only for dementia prevention, but a whole range of other issues. So we might just stick with you for a second, Nick, and ask you about being a geriatrician. What do you see as the biggest challenges for older people with the people you see?
I guess we are living longer than ever before. We have a large proportion now of the old entering our population base. The challenges, I think most people, when you talk to them about what they want as they grow old, is they're more interested in quality of life measures. Rather than the absolute length of life they have to live, they're more usually interested in good quality life. They value independence above all else. We are now entering, and I'm seeing the surge of the baby boomers. The baby boomers are not ones for sitting back and being told what to do.
No, I'm married to one, so.
They expect to be able to live long lives, good lives, to maintain health as long as they possibly can. They expect to be able to remain living in their own home. And by and large, the evidence supports that they are doing that to a large degree. This, of course, entails significant challenges for the healthcare system, for governments who fund services, both in terms of hospitals and community support. But there's probably never been a better time in the history of this country, if you wish to age well and to age in your own home and remain independent, to actually do that.
And what are sort of the patients that you see? What are the main issues that they're dealing with? What are the sort of things that pop up?
So when do you finally front up to the geriatric medicine clinic at St Vincent's Hospital? When does your GP finally decide it's time?
That's a good question. Yes. At what point do you?
Well, most people in this audience would be thinking to themselves, "I hope never." The term geriatrics has negative connotations. Geriatricians, the term geriatrician has negative connotations. We tried to change our names, but it didn't work. We couldn't come up with anything better.
I was going to say, what was the alternative? Maybe we can workshop and brainstorm.
Ridiculous terms like care of the elderly physicians, things like that. We absolutely. So we are geriatricians. We are what we are. When do you want to involve a geriatrician in your care? Well, most people who live in parts of Sydney, like the east and the north, as they age, will accumulate a progressively large number of single organ specialists who probably do a fantastic job looking after various single organs, and are probably...
So you mean like you might have a cardiologist?
You will have a cardiologist, you may have a gastroenterologist,
yep.
You will have an ophthalmologist, you have a lot of single organ specialists. And some people in the audience might reach the point where they think, look, I'm spending half my life running around to these various single organ specialists.
Could one person just handle this for me?
And how come I'm not feeling so good?
Right.
And wouldn't it be good if I didn't have to go and see a whole lot of single organ specialists and could actually perhaps go and see less?
Well, and someone who just treats the whole
person. Yeah, so I think the term frailty is important. We use that term frailty, but essentially what we're talking about there is the slow but steady accumulation of a multi-organ dysfunction.
Right.
The lack of what we call physiological reserve. And that's one of the key definers of what we...
And what do you mean by that? What does that term mean in like practical terms?
Physiological reserve is really the added capacity we have across single organ systems to withstand insults. So by an insult, I would mean an acute illness of any type. It might be a new medication, something like when you and I perhaps develop an acute illness, we expect to feel a bit ordinary.
But you can bounce
for a couple of days.
Yep.
We might stay home, particularly in the COVID era. We'd now definitely stay home, of course, but we'd probably expect to bounce back fairly quickly. If you have frailty or lack of physiological reserve, that can actually, a simple acute event, like an infection, like a new medication, like a fall and a bang on a head, can set off a catastrophic decline in function and ability. So it's that category of patient that may end up coming to see a geriatrician. And we work in multidisciplinary teams as geriatricians. We work across the spectrum of allied health with physiotherapists, occupational therapists, social workers. Elderly patients with frailty have complex medical, psychosocial needs, and we structure our service to try and address those across the continuum. I'm not saying that we don't have a need for single organ specialists in elderly people. I absolutely think that's important, but also think sometimes it's important that we have the ability to manage patients holistically.
Definitely. And look, as the population's getting older, we know that the pressure on geriatric services is also increasing. What do you think needs to be done to improve access to holistic care for patients as they age, both so they can get care either at hospital or at home, depending on where they need it?
So we need to structure integrated multidisciplinary geriatric services across the spectrum of care, from the acute hospital to the subacute care phase and into the community, and particularly in the community. It's particularly challenging in the acute hospital system, particularly in the post-COVID phase. Bruce has referred to, Bruce has been doing some work with COVID. We're seeing now, interestingly, a surge of presentations of the frail elderly people into the acute hospital post-COVID, and not necessarily with acute COVID infection. 2 years ago, we saw huge numbers of acute COVID presentations, extremely unwell, very high mortality rates in the elderly. The whole face of COVID in the elderly has changed. We are now seeing patients, dramatic drop in the mortality rate of COVID infection in the elderly. But interestingly, we're seeing this presentations post-COVID now with things like functional decline, acute cognitive decline. We're even seeing some interesting structural brain changes in patients post-COVID that we don't fully understand at the moment. We're also seeing the consequences of 2 years of isolation of old people, frail older people in the community, of neglect of various aspects of their care, including their primary care, their cancer screening, along with the effects of isolation, the loss of some of these lifestyle interventions, so lack of social and cognitive stimulation, lack of proper assessment and management of their blood pressure, cholesterol and vascular risk factors. So we're seeing this interesting surge now, and it's been quite a challenge to deal with that. Old people presenting to hospitals have complex needs and require specialist assessment and upfront multidisciplinary assessment. The structure of the emergency department, for instance, is not conducive in most public hospitals to efficient and effective rapid upfront assessment. It's a terrible and challenging environment for frail elderly people, particularly those with cognitive impairment, dementia
or delirium.
And delirium. Like we'll see delirium.
Delirium's so common.
That's right. Up to 50% of our patients presenting to a hospital emergency department will have an acute delirium. If you walked into the St Vincent ED today, you would be seeing 30 to 40 patients lined up in a very large room with no natural light, with constant noise 24 hours, 7 days a week, and many of them will be stuck in that environment for a period of days. We need to do better with designing services to assess these patients rapidly and remove them to more appropriate assessment areas.
Well, that leads on to my next question, which is that plans are underway to redesign the ward here at St Vincent's, the geriatric ward, into a more dementia-friendly environment, including a wellness room, which is going to be more holistic and a calming space for people. Can you talk a bit about that?
Yeah, well, the Curran Foundation generously supported the development of a wellness room on our acute geriatric ward at St Vincent's a couple of years ago. That's a place where an elderly person who's acutely unwell and on the ward can actually go, where it's set up like more of a lounge room type setup at home with a comfy couches, place they can eat their meals, television, some music and all those sorts of things. It's just the beginning. I've also been involved recently with the architects in the development of the potential new Carl Cater development at St Vincent's Hospital, and involved in the design of a modern geriatric ward, which is an interesting concept, and there's quite a lot of literature on this now about what specifically elderly people need when they're sick in an acute hospital environment. And this, not surprisingly, involves access to space, access to natural light, the ability to walk and move. We also are now seeing one of the feared complications frequently in the hospital of dementia, which is behavioural disturbance with dementia. Patients with behavioural disturbance, particularly following the recent Aged Care Royal Commission, which highlighted perhaps inadequate treatment of these patients in aged residential care facilities, and particularly the overuse of neuroleptic and sedative medication. We're seeing an increasing flow of these patients with extreme behaviours into the hospital. And these patients are a special group, and they need a special environment, they need dedicated space, they need secure environment, and above all, they need specialised doctors and multidisciplinary and allied health professionals with an interest in that area to manage. And that's now been incorporated into the design of the next, hopefully, building at St Vincent's. Yeah.
So you mentioned that the Curran Foundation had funded the wellness room, and that might be a good opportunity just to ask each of the panellists about the impact that philanthropy will have on the work that you're doing and the goals that you have. So maybe we'll stick with you, Nick, to start with, and we'll go through the whole panel. So obviously the Curran Foundation has really helped with that wellness room, but what impact does philanthropy have generally, and will it have on helping to develop the
Well,
sort of care that you want to give your patients?
It can have a very significant impact. You know, we are keen to sort of, we have plans in and proposals in place that are ready to be activated, provided they can be funded. Of course, we don't have enough funding through public models of funding to fund everything that we need. We want to develop acute multidisciplinary teams to move into the emergency department, for instance, where we can actually assess patients immediately on presentation to move them out of the emergency department. These sort of programs predominantly in geriatrics require staffing and funding for staffing. So philanthropists and the current foundation can greatly assist with programs like that. And there are many more programs that we have ready to go if they are funded.
Fantastic. And I might just ask both of you as well. So what difference does philanthropy make, or will it make, in terms of you getting closer to these goals that you have for your preventative clinic that you want to set up?
You know, I think that it is true that there's billions of dollars invested in treatment options and that they have not so far been successful. And we are all extremely hopeful that there will be something that will come and that will be a kind of fix-it. But we do know that prevention can be helpful and can work. And at the end of the day, really, what you want is one person. You know, do you make a difference for each person, one person, that person? And we know that inevitably that will be helpful. It's not well funded. The funding tends to go towards other bigger things, and yet the potential to impact on one person and on one community and on one family and on two families and on, you know, it ends up with the impact on each person. You have an impact that's much, much, much broader. And really, when you impact on something in a preventative way, that's the medicine all of us want to practice. We want a medicine that we keep people well, rather than a medicine that we wait for somebody to be unwell and sick in the emergency department. We want to pull that back. And hopefully philanthropy and funding that can sort of support the kind of preventative work that's needed will be helpful both for individual people, for the patients that come, but also more broadly for the community. So it is something that's very much reliant on philanthropy.
And Bruce, from your point of view, and after Bruce answers, I'm going to go to the audience. So you'll be thinking about your questions. And we've got Sarah with the microphone. She's going to run around. So just raise your hand if you've got a question and she'll come to you.
So I think philanthropy is actually absolutely critical for research, both at a basic level and translational and clinical research. I say that because the governmental funding bodies have a 10% success rate globally across the board.
We'll just get you to go over that point again. So if researchers are putting in for a grant through the federal government's body, what's the success rate?
So 10%.
So 10%. So only 1 out of 10 will get funded. The rest don't get funded.
Yep. And so you waste a lot of time writing the grants and so forth. So, and government has as its key performance indicator the output from the grant, and so they will not fund things that won't have an output that is tangible in a short time frame.
So they don't think long term.
They don't think long
prevention's
term.
Obviously long term.
They're not elected long term, and they don't think long term. And pharma, it's not in pharma's interest to fund a preventative strategy, to be frank.
Because it will do them out of a job.
Out of business, unless it's a preventative tablet, like a polypill, which of course has been around for a while.
Yes.
Tech may be interested in preventative strategies, but it's tough. It really is tough. So philanthropy is critical.
Fantastic. So we're going to go to the audience. We've got a question here from the online audience, so we might go to that while, if everyone wants to be thinking about questions. And the question is for Bruce. Bruce saying, can you tell us about your research into adult neural stem cells? Which I mentioned very briefly in the introduction.
Yeah, so that's been something we've been working on for quite a number of years now. And originally we were interested in infusing stem cells in various mouse models, and that didn't take flight.
And what sort of conditions were you looking at treating?
So we've used an inflammatory model because inflammation does seem to be really critical as a driver for a lot of degenerative diseases, and you want a short time frame. So we've used MS.
MS, yeah.
Yep, an MS mouse model. But there are other models, and there's an Alzheimer model that Bryce, our colleague, will help us with and in which he's worked. But the strategy more now is trying to harness your own stem cells. So you have stem cells within the brain. For a whole host of reasons, they don't seem to work particularly well. They do work well in London taxi drivers, where there was that famous study a few years ago where they certain parts of their brain became larger as a consequence.
That's because they just knew the maps so well and where they were driving.
They had to be instructed. That's right. And after navigating through London can be difficult.
So it is a use it or lose it sort of thing with your brain too, isn't it?
That's true. So you can certainly harness some your own stem cell activity. The mechanisms by which you can do that are still not clear.
Right.
And that's been the focus of our research, including Bryce's and lots of other groups. Yeah.
Okay, so it's still pretty early.
Very much early.
Now we've got another online question, and then we'll go to the audience. So we've got a question down here, Sarah, if you want to come down, and it's to you, Nick, asking, how do we encourage medical students to choose geriatrics?
Oh, great. Well, actually, the evidence is we've been pretty good at it. I think
certainly not becoming GPs, that's for sure.
Look. I mean, I think we are the second or third most popular specialty for advanced training after, I think, cardiology and gastroenterology. So we are attracting the young ones in. I think what's really important, like any specialty, is excellent role models for young doctors and medical students. They will all rotate through rotations in geriatric medicine, both in the hospital and the community. And I think really it's very important that they see excellent role models. I think also the patients have a great ability to be appealing to students and young doctors. Some of the outcomes that we're achieving with really sick elderly people can be fantastic. I think there's possibly a little bit of pessimism about what we're doing in acute care of the elderly.
So that what you can do can really make a difference to people's quality of life.
Oh, absolutely. Absolutely. Patients who present with delirium, for instance, the vast majority of them, their delirium will resolve, and many of them will get back to somewhere close to their previous level of function. And following often a complex process of acute and subacute care, many of them will achieve their goal of returning home. We also have the ability now with transitional services to support elderly people as they move back to the community much more closely and intensively than we have previously.
Fantastic. Well, hopefully that'll continue to get lots of medical students. We've got a question here and then we'll come to you, sir.
Hello, thank you very much for tonight. I'm a little confused about the difference between dementia, delirium and Alzheimer's. You've talked about how to lessen the impact, but are they all the same? I don't think they are. If it's not too broad a question.
No, not at all. So did you, Shiva, or Bruce, did you want to answer that?
Sure, we think of dementia as a kind of umbrella term for a degenerative, progressive neurocognitive problem. And that includes things like vascular dementia, it includes things that we'll call Alzheimer's dementia, it includes frontotemporal dementia. There's lots of different things that will often present clinically quite differently. Sometimes on imaging they can be quite different. Sometimes the kind of biomarkers or tests that we do can be different. And so we sort of distinguish them in a way to try and help see whether different types of dementia might benefit from different kinds of treatment. When we think of delirium, we think of a kind of acute rather than a progressive decline. We think of some acute kind of decline that's happened abruptly, often in the context of infection or some other precipitant, usually in somebody whose brain is vulnerable for some reason. And then that can improve, and that's what distinguishes delirium from dementia is that capacity to improve, and with good care, people do.
Your point, though, about the terminology being confusing in this area is very valid. It is. I mean, patients often say to me when I raise the term dementia with them, they say, "Thank God, doctor, I thought I had Alzheimer's." And you're really struggling after that. But the terminology is confusing. And I think one of the challenges for us is to try and simplify that terminology.
But Alzheimer's is the most common form of dementia, isn't it?
Alzheimer's disease.
That's why we sort of hear a lot about Alzheimer's disease.
Yeah. Although, of course, the longitudinal autopsy studies of patients with dementia suggest that really, when we talk about Alzheimer's disease and the specific neuropathology that we know is associated with that, when you look at these brains post-mortem, most of them will actually have mixed pathology and the accuracy of that clinical diagnosis. But of course, now with modern imaging modalities and particularly the ability to identify biomarkers of the particular dementia syndromes, diagnostic accuracy has improved significantly.
Fantastic. Okay, we've got a gentleman here, then we've got one up the back, and then we'll go to this lady.
In terms of the 12 risk factors, it's clear that there's just the general stuff: be healthy, don't eat a lot of fast food, all the usual stuff that applies to anybody. But when it comes to exercise and working on your cognitive, this is not clearly understood. I mean, I noticed that on the internet, and a friend of mine actually is associated with Lumina, which has all these bizarre exercises to keep you intelligent.
Like the brain training sort of
But that's
programs.
just a way of making money. So the question is, what specifically should we all consider to keep our brains agile? Is it learning another language? Is it doing a complex hobby? What is it that we should consider doing as we get older? Because it's very easy to say, oh, do something with your brain, but
What do you mean by yes? Yeah, so what's going to be the most beneficial?
High
Bruce?
levels, very shallow.
What's going to be the most beneficial for people?
So the physical activity aspect, I think, is solid, and that's quantifiable. The steps I mentioned, that's got a good evidence base behind it. The WHO recommendations talk about 300 minutes of aerobic exercise per week. So that's solid. The cognitive activity is not solid. Completely agree. And it's confusing. It's not clear whether participating in learning another language or any other type of cognitive activity necessarily has spillover benefit. That's still not clear. And there are some advocates who are quite firmly convinced that there is spillover benefit, and equally there are others who aren't. What do you do at a practical level? There's no harm in, there's no downside in encouraging the patient to be more cognitively active, except disappointments born of unrealistic expectation. So you need to be, I think that's where the holistic aspect of intervention is so critical, because you're going to encourage them to do more cognitive activity, but you don't want to encourage them to do more activity that will reinforce their problems.
Mm. And is it also, I think I read one paper where it was about doing different things with your brain. So if you'd always, played a musical instrument, then it might be a good time to do something different,
Conceptually, that's attractive.
Yeah. Is there any evidence to it?
No.
Oh, no. Damn.
Not that solid. I'm happy to be corrected.
And I think also it's very hard to do those kinds of studies for lots of reasons, different educational backgrounds, different interests. And, if we took an audience and asked everyone to do Sudoku or something, the people who like doing it will probably be able to attend to it more, do it more, and somebody like myself will
not do it.
So it's, I think encouraging people to find things that interest them, and all of us have interests, whatever they are, encouraging people to do those things and keep their mind active. There is, one of the risk factors that was identified is educational attainment, and so young people, encouraging them to progress in their studies. And again, it's not clear exactly why that is, but it does speak to a potential, a theory of cognitive reserve. Yeah, that if you've got more connectivity, if all of those synapses are more active, is it possible that just creates a reserve that the same kind of injury might happen, but the person's less likely to show declined cognitive changes in that context? That's possible. I don't think it's a recommendation that's not likely to do harm, that would easily, provided you tell.
And it might do some good.
Yeah, that it's, find something that interests you, whatever that is.
All right, we've got lots of questions, so I want to get to as many as we can. We'll go to this lady here, and then we'll go up the back. Thank
you. Yep. Hello, I'm Renee Brack. I've made a film called Tickety Boo about my artist father's Alzheimer's. and how it wasn't the disease that damaged my relationship with him, it was my own fear and ignorance. So I decided to confront my fear and ignorance by having a series of tests to see what my future holds, against the advice of Ita Buttrose and various luminaries that are in the film. And Professor Parminder Sakdev arranged for me to have the tests. I now know what my APOE status is. And it was a surprise, and it's a big turning point in the film. But there was no support. I literally just was sitting in front of the computer looking up sites in Germany to find out, what do I do now? And I've become very much an activist for dementia prevention because of this as well. And I'm doing a PhD at UTS on impact, and I've got an initiative coming up. And so I love that I am someone, but I'm the only person I know who's doing it. Where do we go when we find out a little clue that something isn't right with us or may not be right with us? Because I just feel like I'm just doing my own research without much guidance.
Come to us.
Yeah, I would see the great people at St Vincent's.
I mean, that's the whole point of the prevention clinic, and having a multidisciplinary approach, multi-domain as well as multidisciplinary.
Okay, we'll just take the gentleman up the back, and then we'll go Sarah here.
What we've all forgotten is trauma and how that affects the brain, and dementia. We've got always talking about footballers getting concussion and how this affects them, and you've got people who are 60 or 50 complaining of dementia-type symptoms. How do we recognise when we should stop these people from pursuing their endeavour on the sporting field early so they do not develop dementia?
Do you have any thoughts, Bruce? I mean, we're not going to hold you to it to say...
Yeah, I mean, it's a loaded question, isn't it, Peter?
I mean, we certainly know there's a lot more awareness these days, isn't there, about the impact of repeated knocks to the head that can happen.
Yeah, so, I mean, there are studies, and they're around the world and including in Sydney, that are trying to grapple with this in a much more quantitative way. One aspect would be a blood marker like neurofilament light chain. So it's a blood marker you can measure that indicates nerve damage. And that holds promise as a tool by which to say you should stop whatever
you're doing.
Yeah. There are other tools as well, but that's one of them.
Okay, we've only got a few minutes left, so we'll quickly go question here, and then we'll go here, and then we might need to wrap up after that.
Apologies in advance, I might have a bit of a contentious question. So this lovely lady over here that's doing her own research at the moment, I personally can relate to that because I've had 5 primary cancers, not related to neurology. I find myself in a similar situation where I'm doing all my own research. There is no longer one physician, if you like. I used to be under Ron Penny, which I'm sure a lot of people know. There is nobody in my world that exists like that anymore. Professor Brew, my dad does see you. You've just said you come and see us. So in a situation where somebody does have a marker for Alzheimer's, what actually are they to do? It's not government funded. You have to be somebody who has a decent bank account. You cannot rely on Medicare. What are you to do if you are not in the high socioeconomic situation? What are you to do? I can't come and see you and say to you, my dad has Alzheimer's, I've had 5 cancers, what do I do now? I can't come and see you. What do you suggest somebody like that or this lovely lady over here is to do?
Yeah, so I'm a bit puzzled, to be honest. Getting to the nitty-gritty, I don't charge people when I see them. So there's no economic issue.
Because you're through the public hospital, so
so there's
no charge involved.
There's no charge involved.
And certainly
I deliberately use the imaging facilities so within the hospital, so there again, there's no charge. So, from the financial aspect, the basic services, no charge. There is always, however, additional aspects of care, like psychological support, that are really difficult, and yes, there's a service within the hospital. Is it available in real time? Absolutely not. And that's where philanthropy can help with service provision that should be there and isn't there.
So we need to wrap up. Have we got any last questions? We had one more question, I think, here at the front, and we better wrap up.
Yes, mine is short. Is alcohol one of the 12 causes, and to what extent?
Good question.
So the short answer is yes. And several years ago, it was thought there was a U-shaped relationship, that a little bit of alcohol was probably good and more was not good. The actual recommendation and the data would suggest that mild to modest consumption is probably all right, but from a whole host of other perspectives, little to no alcohol is better. Now, what does that mean in particular terms? Well,
that's the bad news, folks.
It's hard. Perhaps, 10, maybe 1 to 2 standard drinks a day, and that'd be tops probably. But there's a lot of variability, and equally, it becomes very complex because alcohol consumption in small amounts is a social lubricant. Social isolation is negated by alcohol. So it's a complex picture.
But certainly, but overuse of alcohol or heavy
Absolutely.
use of alcohol is definitely not.
No question. Yeah. Overuse and modest use, to be honest, in the sense of moderate, is probably not so good. So
fantastic.
Minimise.
Well, look, we could keep talking about this for hours, but we need to wrap up. It's been a fascinating discussion, and I think we've been able to really just be so excited about what the future might hold for prevention of dementia, which is something that, even a few years ago we might not have even used those phrases. And St Vincent's and the Curran Foundation really are going to be at the centre of this great revolution in brain health, and that's the amazing thing about having these great doctors and scientists working here on this important topic, because the work they're doing is going to be helping people, not only helping people now, but also really in the future, with that really important focus on prevention, because as we said, much better to get in and do what we can now. And also I think that message that Nick gave about it's never too late, that's the other really important message. No matter what age you are, you can make changes, you can make small changes, and they can actually have a big impact. So I hope you can take some of these messages on board and think about what you might be able to do to look at those 12 factors. And we can actually, we'll send you the links to the documents if that's helpful, so you can see what those 12 factors are and which ones you might be able to apply in your own life. And but everyone, why don't you give a big round of applause for our amazing panel. Thank you so much. And thank you everyone in the audience for your support of the Curran Foundation. We couldn't do the great work that St Vincent's does without your support, so thank you very much.